Okay, so I'd like to acknowledge the local custodians of the land in which we meet this evening and honour elders past, present and emerging. I'm Melissa Wilkinson from the Primary Health Network's education team. I sit on the Central Coast, so welcome. We've got a jam-packed session tonight with lots of presenters and lots of content to get through, which is really important and vital, of course, at this time with us living with COVID. I'd like to hand over now to Dr. Kat Taylor. We're going to give us a quick update on the current situation with COVID. So thanks, Kat.
Thanks, Mel. I've just got a couple of slides. I don't know if you can allow me to share those.
Sure. There we go.
Thank you. All right. So, okay, can you see that?
Yes.
Excellent. So thanks. This was a bit of a last-minute invitation, but I thought it was timely to give everybody a bit of a quick update. As we know, COVID is constantly throwing us curveballs, but we did enjoy a period of relative calm for the last few weeks, with declining case numbers, and actually our first donut day on Sunday, the 21st of November. So that was quite an achievement to get to that point in the Delta outbreak. But then, of course, no rest for the wicked, and there's now a new outbreak, a new variant on the block. So I just thought I'd quickly share with you a brief review that we did of the Delta outbreak locally to date. So just a quick chronology here. Sorry, are you guys seeing that panel as well? Do you want me to? I can close that, maybe.
No, that's fine. Great. Yeah.
Okay, beautiful. So as we know, it all began back on the 16th of June, where we had our Bondi limo driver. By the 23rd, we had 6 LGAs placed into lockdown, which quickly grew to 12 LGAs of concern, and also restrictions across Greater Sydney, which we were in again, out again. But yes, so including Central Coast. Then unfortunately, it was probably a bit too late by that stage. The Bondi cluster was already at 124 cases, and we went into kind of an emergency response structure. 2nd of July was when we had our first locally acquired case on the Central Coast. And then we had a period of, relative calm in terms of numbers. We were surged maximally to assist with Southwest Sydney, particularly where the outbreak was really taking off. But it wasn't until the 8th of August that we really got our first unlinked locally acquired case here on the coast. And then probably, a couple of weeks later, we had our first unexplained sewage detection, which was up in the Baddo Bay catchment, which was probably reflective of, undetected community transmission. We really reached a peak, as you would know, in sort of the beginning of October. And then, all the while vaccinations were sort of following on the march, and huge commendation to the collaboration of the primary care sector in achieving that 70% first dose target by the 6th of October. Then we had the heralded Freedom Day on the 11th of October, where restrictions were eased for the fully vaccinated, and we all held our breath and waited. And on the 15th, we did achieve an 80% double vaccination rate as well, which was great. And as I mentioned, just last Sunday, we had our first local 0 day. So I guess it was quite a different presentation, about 3 days ago, where we were talking about stabilising statewide numbers. Maybe a slight uptick again in some of the previously affected metro areas. Southwestern Sydney was getting some increased activity again, but overall statewide numbers were remaining stable around the 200 cases per day mark, and things also sort of stabilising in the Hunter region. I won't dwell on that. But basically, just what we've described, that epidemic curve of, a couple of linked cases in the outset, but things didn't really kick off until September for us. And unfortunately, we did have quite a number of cases who were not in isolation whilst infectious, which sort of propagated the outbreak. Just a really quick overview of the demographics of this outbreak. You can see by this very skewed distribution of the ages of cases that the majority of cases are in very young people, and that's probably a reflection, especially towards the end of, a decreased vaccination coverage in that group. And so the median age of cases for this outbreak to date has been 27. So half of cases have been aged less than 27. And you're all very familiar with the impact that this has been having on our educational facilities and secondarily, you know, the people that are looking after children in those education settings. In terms of the vaccination status, you know, we anticipate at the moment it's largely still a disease of the unvaccinated, but we anticipate as population coverage rates increase that we will see an increase in that relative proportion of cases who are vaccinated. And then, unfortunately, you know, the First Nations community who were so fantastic at keeping COVID out in the first few waves, unfortunately, once Delta did get in, you know, our fears were confirmed in terms of spread in that community. And unfortunately, in this wave, they've been overrepresented. So some 18% of our cases identifying as First Nations. And, you know, again, a huge shout out to the collaboration between the Aboriginal organisations on the coast and also primary care in really trying to work on coverage rates of vaccination in this population. And I suppose another really interesting thing that we had a bit of a look at was the socioeconomic status. So, I mean, Delta has really been an illustration, unfortunately, in the social determinants of health. This is basically the breakdown of cases reflected by postcode according to the CFA decile. So 8 being sort of the most advantaged decile. We don't have any 9s and 10s of our postcodes here on the coast. And 1 and 2 being sort of the least advantaged or most disadvantaged deciles. And you can see here this expected column is essentially what proportion of cases we would expect to come from these postcodes were the cases distributed randomly according to the population within those postcodes. And you can see here that there's basically a significant underrepresentation of expected cases in the more advantaged postcodes. And then by contrast, also or corollary, should I say, an overrepresentation of cases coming from the least advantaged postcodes. So that's just a sort of vignette of what's been happening to date. Testing, interestingly, hasn't really kept track with what we've seen in terms of the actual local activity. So there was a very big spike when things kicked off locally and, you know, there was quite a bit of comms about COVID's here and we've probably got transmission. But we've never really reached the dizzying heights of, you know, back at the end of July in terms of testing, even as case numbers have increased. And I suppose that speaks to the fatigue of the community and healthcare practitioners in that space. And I guess just to sort of take stock of some of the key public health achievements, a huge number of local cases interviewed, numerous close contacts and not just initial calls, but, you know, ongoing calls to these people. Also fielding a lot of public calls coming in, staggering amount of venue assessments as well. So exposure sites that cases have visited, including high risk locations, some of which include your practices and educational facilities. Also ongoing active role in terms of surveillance for adverse events following COVID-19 immunisation, which we do, you know, take the notifications for and report up to TGA. And again, you know, really commending those external partnerships that we've had. And yeah, and some research. So that was just a bit of an overview of where we've been. But as we know, things can sort of change almost overnight, it seems, with COVID. So we're now familiar with this new strain, variant of concern, which has been designated Omicron. And there have been a number of quite rapid policy changes to returning international travellers that have been brought in response to that. And so I won't spend a long time talking about it, but effectively there are a number of sort of African countries of concern where people who have returned from those countries in the past 14 days are required to self-isolate for 14 days. Rather than sort of being subject to the usual freedoms of quarantine-free entry into the country if you're double vaccinated. So that goes for people who've arrived prior to the 28th of November, that was Sunday. And then for people who've arrived since the 28th, a public health order was brought into force Saturday midnight, basically requiring people from those affected countries to quarantine in a hotel quarantine facility. So There's been a rapid sort of upscaling once again of the special health accommodation to accommodate those people. And then there've also been some additional precautionary measures brought in for anyone returning from an international destination, which is that they're required to self-isolate for 3 days and have evidence of a negative PCR test before they can leave self-isolation. And this is still very much a live space in terms of the policy settings. I guess that sort of 72-hour period was put in place kind of on Sunday, while more information is gathered, and it remains unclear as to, I guess, what the ongoing policy will be with people returning from other locations. So those are the current settings with respect to international travellers. There's still uncertainty in terms of what the requirements are for people who are living with returned international travellers. So that's something that we hope to have clarity on over the next day or so. And I guess the other big change that's kind of caused a lot of confusion over the past week or so is the rapid antigen testing in educational settings. So this is a policy decision. I won't get too political, but anyway, it's a bit of a deviation from, I guess, our previous public health practice, in that people who are close contacts of an educational exposure, so children who are close contacts at an educational facility, are being enabled on a voluntary basis to participate in the RAT testing program, rapid antigen home testing program, which requires that they self-isolate until they receive a negative PCR initially. Then they're given a set of rapid antigen tests which are provided by the education department. So they're approved kits which are supplied, so they get 7 of those. And then they are required to test every day, which will enable them to actually return to school immediately, providing they've had a negative test. What happens after the 7 days of rapid antigen testing is still a cause of confusion. So currently the policy on the education website suggests that, and sorry, should I say during that 7-day period where they're allowed to go to school with the negative RAT testing, they are still under self-isolation when they leave the school grounds. So they're not to go anywhere else. It's basically just school and home. And then following having had the 7 negative RAT tests, currently the advice is that they can leave isolation and return to educational activities and the community as normal, which again, as I mentioned, is a deviation from what we have done and inconsistent with other advice. So we are urgently seeking clarification on the implementation of that. But it was a change that came quite quickly, and I think ostensibly to sort of align with what's happening in some other jurisdictions. So I'll just stop there and maybe take any questions.
Okay, if anyone has any questions, you pop those into the box down below. And I'll also say thank you very much, Kat Taylor, for being with us this evening. We really appreciate your time. We know how busy you are at the moment. A little bit of housekeeping. There will be a poll at the end, and strongly encourage you to complete that poll. We get our data from that to plan future events. Please utilise the questions box. We've got Dr. Karen Douglas who will be monitoring that box this evening. Thank you, Karen, for that. And we want to have this session as interactive as possible. So this is your chance to ask those questions. And I'll now hand over to Dr. Ellie Warren, who will introduce the further speakers for this evening. Thanks, Ellie.
Thanks so much, Kat, for that quick update. That was really nice to have you on, as always. It's very nice to have you at the last minute too. We really appreciate it. I wonder if you wouldn't mind if we did have some questions later on in the night that we struggled to answer ourselves. Are you happy if we contact you for some clarification, and we can get back to the attendees with some answers if needed? But I think that was a fantastic snapshot. Yeah, thanks, Kat. We'll let you go because I know you're a busy lady.
Thanks, everyone.
Thanks so much. So thanks everyone for joining us tonight. It's wonderful to have you on. We've got, I think I've heard the most panellists and presenters that an online PHN event has had. ever, so it's a cause for celebration. But we will have first up, I'll go through the speakers just to introduce us all. We didn't have time initially. So we've got John Bailey, who's the Executive Manager of Primary Care Improvement at the PHN. He's going to be talking to us about the Commonwealth's Living with COVID model of care. And how that relates to GPs. We also have the strong representation from the hospital, thanks to Dr. Elizabeth Renicky, who's Head of Department of Neurology and one of the senior medical officers of the COVID Community Support Team. Melissa Pickering is Director of Nursing and managing the COVID Community Support Team with Jerry Yu, who's Connecting Care Manager. So we're grateful to have you guys on board tonight and tell us how we can all cooperate and collaborate to look after patients with COVID in the community. So there's strong representation from GPs, which we're excited about tonight. There are 4 of us online, and we wanted to just really highlight that there has been a strong GP voice in bringing these models of care together, and we've been advocating for general practice and poking and prodding where needed to make sure everything makes sense to GPs in a really evolving and dynamic situation. So you can always reach out to us. I'm Dr. Ellie Warren. I'm Chair of the Central Coast GP Collaboration Panel and Co-Chair of the Central Coast GP COVID Community of Practice. We've also got Dr. Karen Douglas, who's a GP in Terrigal and Chair of the PHN's Clinical Council. She's Co-Chair with me of the Central Coast COVID Community of Practice and 2021 RECGP of the year. If I had sound effects for applause, I would push that button. Amazing to have you online, Karen, and to have you working with us on the Central Coast. Dr. Catherine Palmquist also works in Terrigal. She's a GP who's been working at the Erina Respiratory Clinic and involved in managing COVID patients in the community out west in Dubbo. She's also the GP Clinical Advisor for COVID and Disaster Response here on the coast. We have Dr. Jill Sass, who's a GP at Point Clare and GP Clinical Editor of Health Pathways, working really hard to get those pathways up and operational so we all know how to work out what to do with our positive patients in the community and who to call for help and how to escalate care safely. Erica Drew will be helping her present those latest up-to-date models. So let's get straight into it. John, I'll hand over to you. Thanks so much.
Thanks, Ellie, and thanks everyone for joining us. What I'd like to do very quickly is set the scene with some modelling that we've received to help you understand what we are likely to see and why we need to involve GPs in the care of positive patients in the community going forward. Next slide, thanks, Mel. Just want to put in context the next set of numbers and give you a bit of a local point of reference. So in the Hunter, New England and Central Coast population, or in our footprint, we have a population of about 1.3 million people. It, in geographic terms, is an area the size of England and extends from the Hawkesbury River up through the New England to the Queensland border, out as far as Moree, which has been a spot of local significance recently. For the Central Coast, your numbers are approximately 325,000, or 25% of the overall numbers of our region. Just draw your attention that these slides are for planning purposes only, and they are being refined. The model is being developed. Thanks. Just some assumptions and some background to the modelling. So the modelling is done by the Doherty Institute. It's done at a national level. Then it's estimated daily COVID-19 infections at a postcode level. And then they're re-aggregated, the postcodes, to the PHN level, just to take out some of the noise from changing vaccination rates and other factors. We hope in the future to be able to get some modelling at a postcode level once vaccination rates stabilise. Just also want to draw your attention that some of the numbers I'm going to show you are based on a few assumptions. Firstly, that domestic borders will open from the 20th of December. Now, we know that will be the case for most borders, but not necessarily all borders. So Western Australia being a case in point where it's unlikely that their border will open until early 2022. It's also predicated on the assumption of an automated triage of 20% of patients being high risk, that is, they are over 65, have a comorbidity, and therefore likely to be placed in the high risk category and under the care of the public health unit or the public health system. The remaining 80% are for referral to GPs. Vaccination coverage for this set of calculations has been done at 80% of the population 16 and above. Just to note that we will request additional modelling now that we've reached 90% and as vaccination rates increase, because it alters the curves that we're going to see shortly. And the vaccination rates lower the level of symptomatic cases and hospitalisation as a result. These are also modelled on baseline public health and social protection measures. Those are similar to what those that were in place in March 2021. In other words, basically where we are now with some loosening of the square metre and the numbers of people in venues. The other thing to draw your attention to is that the large number of undetected asymptomatic and symptomatic cases are likely in this case scenario, and we'll see why that's important shortly. The other assumption is that cases remain active for the current 14 days. We're aware in some overseas jurisdictions they've changed that period of active case. Next, thanks, Mel. So the first set of slides and numbers that I'd like to present to you are the daily new cases. So these are new symptomatic cases modelled on the population that we have, vaccination rate of 80%, and all of the other assumptions that I talked about. The graph on the left is our daily new symptomatic COVID-19 infections where the cases are detected and reported to the community. So that's with high testing rates and significant reporting. The graph on the right, the daily new modelled total COVID infections, is a graph that indicates numbers where 70% of asymptomatic cases are not detected and not reported. In other words, people are asymptomatic, they don't present for a PCR test, they are therefore not picked up by the public health unit. And we're already starting, as Kat said earlier, to see some testing fatigue, and we're seeing people who are asymptomatic but positive not necessarily coming forward to be tested. Just a couple of points there. You're seeing a peak there of 2,853 in mid-April. That's a peak. That's not every day. That's at its peak. But with a curve for medium caseload at 444 and a low caseload at 41, based on varying public health and social protection measures. Next slide, thanks, Mel. This is the slide that talks about active cases. So this is the cumulative number at any 14-day period. What we're looking at are daily active symptomatic cases of 8,522 under a high caseload scenario, down to 137 on a low caseload scenario, with the medium caseload scenario being 1,322 active cases at its peak in mid-April. Under the scenario of 70% of those asymptomatic individuals not being coming forward and being detected, the modelling suggests that there could be up to 39,000 active cases in mid-April, 6,000 under a medium caseload, and 629 under a low caseload. Now again, that's all predicated on the 70% asymptomatic cases not being detected and not coming forward and not being detected by the public health system. Thanks, Mel. Okay, so why show you those numbers? Well, I wanted to show you those numbers to highlight for you the key part that general practice and primary care will play in high volume numbers. Now, those numbers, as I said, are for the whole of our region, with the Central Coast equating to approximately 25% of those. The model that the Commonwealth are looking at is a model using general practice to provide the support to those in the low to moderate risk group. There is an expectation that a large number of the cases will be able to self-care. In other words, they will not require the active management of a GP or a practice nurse or others. What we will see, though, are some people who have undetected comorbidities or other issues that will require the active management of a general practitioner. And Karen and Ellie and others will talk about what's proposed in this region. The Commonwealth are currently funding PHNs to undertake a rapid commissioning of home visiting services for those who are at risk of deteriorating and to prevent them presenting to hospital. We'll release an EOI for that on Wednesday of this week, and you should receive an email in your practice email box alerting you to that release either tonight or tomorrow morning. The MBS item numbers for telehealth will continue through to December, and it's expected that they will be extended. There is also the additional, very generous $25 additional payment if you see COVID positive patients either in their home or in your practice. I'm probably happier to answer questions now, but then hand over to the others to fill in their part of the presentation. So Ellie, over to you.
Thanks, John. We've got a couple of questions that have come through already.
Sure.
It might prompt a bit of discussion around it, but Dr. Nat Cordowina has asked, in the current climate, how will our practices be treated, managed and closed, etc., if we find out a COVID positive patient has been in the building, given that we are now living with COVID and those numbers, the modelling is pretty chilling.
Yeah, so I think a couple of things. The modelling is something not to be scared of. I think that we need to recognise that most of us have been managing this quite well over the last 18 months or so. As vaccination rates increase, we're likely to see lesser impact. And once we start vaccinating the 5 to 12-year-olds in the early new year, based on the current ATAGI advice, we're also likely to see a lessening of the impact, as you saw from Kat's slide, the significant numbers in those younger age groups. So early vaccination of younger people. And the final thing is we shouldn't underestimate the value of the booster or third doses in reducing the impact. Now, I'm going to say all of that, but I'm also going to say variants aside. So we need to wait and see what happens with variants. Because they're a little bit like the Joker in the deck of cards. We don't know when it's going to come out, and we don't know what it's going to look like when it does come out. So the furloughing issue is one that is a live conversation between the Commonwealth and the states. The expectation is that for practices where you have been wearing PPE, particularly P2N95 masks and goggles, so eye protection, that you are less likely to be furloughed. Now, that is being worked through at a policy level, and that's something that the Commonwealth have taken up with all the jurisdictions who apply those rules. We're hoping that an announcement will be made in the next few weeks on that, so that general practices can have some certainty of the impact of having a positive case within your building. Now, it may be that we end up with a situation where if you're wearing full PPE and you're working in that sort of environment, then the furloughing is less of an impact or no impact than if you're not. So a big plug for wearing particularly N95 mask and goggles when you're in your practice.
Yeah, noting that it's a changing space and we're more likely to know policy decisions next year, I guess. But importance of PPE cannot be overstated, yeah. I wonder if just briefly it might be good to just, I guess, go over an example of what we're expecting GPs to do when we're talking about managing the 80% of low risk and asymptomatic positive patients at home. We have certain tools as general practitioners to do that. So we've got ongoing telehealth, and hopefully that will continue to allow us to link in with our patients at home. We might be able to get a better feel for it after the LHD team talks about how the community support team links in with everything. But John, is it worth just describing slightly your home visit EOI that you
Sure.
are looking for practices that are happy to ideally perform home visits for their own patients who are borderline, do we need to send them to hospital, do we not? That would be where the home visit comes in. Do you want to speak to that just for 30 seconds?
Yeah, I will. So there are a couple of EOIs that we've got out at the moment. One is for practices to indicate that they're willing to care for COVID positive patients. And that EOI, we've got about 31 responses to that. Practices who sign on for that will be able to access PPE from the national stockpile, and patients who are patients of their practice will have access to pulse oximeters through the national stockpile for the practice then to be able to care for that patient, albeit in a remote sense, or if they wish, they can do it face-to-face in the practice. The second EOI that we've got out, or that we're going to put out on Wednesday, is one for home visiting. Now, the concept of this is where a patient is at home, positive, in isolation, they're feeling unwell, but they're not necessarily needing to go to hospital. The idea is that either a GP, a practice nurse, a nurse practitioner can go to, or a home nursing service for that matter, deputising service in the after hours, can go to the patient's home, don PPE, assess the patient, contact the patient's own GP or deputising service in the after hours space, and get some advice as to how to manage this patient to avoid them needing to go to hospital. The whole point of the home visiting service is, if you like, to head off that transfer to hospital, and we know that that occurs, can occur quite effectively. So the service will be funded by the PHN for those exceptional cases where a patient is deteriorating or potentially deteriorating, but not necessarily ready for the ambulance. The concept is being worked through at the moment, but we're looking to put an EOI out that will look at both in hours and out of hours, and for either your own patients or for other patients in the other people in the community who don't necessarily align with a particular practice. So all of those details will come out in the EOI on Wednesday. My name's down to answer questions, so if you can email me, you can email me those questions. One thing we will need to, because it's an EOI in the sense we'll need to provide those answers to everyone who is interested in them, so that I can't answer specifics about your practice, but I can give broad advice on the approach. And we're working through the rates that will be offered for those in-hours and after-hours home visits.
That's great, John. Thank you. And just quickly before we go to our LHD colleagues, will the GPs be fit tested for N95s?
If they agree to participate in the EOI process, yes.
Great, thank you. All right, let's hear from Dr. Elizabeth Reneke and Melissa Pickering. Jerry, you. Thanks, guys.
Thank you, everyone, for inviting us. So I am Mel Pickering, and yes, as Ellie has said, I'm joined by Dr. Elizabeth Reneke, who has been leading from a medical perspective our COVID response, and Jerry Yu, who is the manager of the COVID support team. Tonight, we're just going to share with you a bit about the community support team and what they do out in the community with supporting our active COVID patients out there. Elizabeth will touch on some of the key partners that we work on, as well as the infusion clinic, and I'll share a little bit of information in regards to the health accommodation that we have still operating here on the Central Coast. So I'll pass over to Jerry first, and he can cover off on the support team.
Good evening, everyone. So my name is Jerry. So I'm managing the COVID community support team. So the COVID community support team basically follows a standardized protocol-driven approach for the provision of escalation of a short-term care. So we're clinically appropriate. So we care for COVID-19 positive patients in their own home using remote monitoring and virtual care modalities to monitor for signs of clinical deterioration. So this model of care builds on existing health and social care pathways and resources, and includes MDT support from specialties such as infectious disease, critical emergency care, mental health, drug and alcohol, pediatrics, maternity, allied health, and GPs. So often, that is because often we found that patients with COVID-19 may not necessarily be mainly affected by COVID-19, the virus itself. Usually it's the comorbidity, it's the mental health, drug and alcohol factors, or maternity or other things that's actually affecting the patient. So that's why we are actually involving a big group of people and then trying to navigate the patients through the different services and providing the necessary care they need. So our hours is from 8 a.m. to 8:30 p.m. 7 days a week, and referrals, we usually get them from the patient flow portal, and then we have our email and contact numbers there. So the elements of the standardized model of care, so there's multiple channels for referrals, and then we follow a risk stratification of symptoms and risk factors that is aligned with the CDNA and ACI caring for COVID positive patients in the community. And also we define regular observations and well-being checks, and we define clinical criteria for escalation of deterioration and criteria-led, which is criteria-led and protocol-informed, and also the discharge as well. And our goal is to actually have a centralized intake point, and this is with the key skills to monitor and refer the patients to relevant services, and also navigate patients through and provide integrated, better value care. And also I'm just going to share with you that the care flow charts that we usually follow as an example. For example, we follow the ACI guideline, ACI caring for adults with COVID-19 in the community, and then we follow the same risk stratification patient flow chart, and then risk categorize them when we admit them through the initial assessment, and we follow a certain escalation pathway and monitor for signs of deterioration. Our key partners, so Aboriginal Health, because the vaccination rate is relevantly low in that population. So we do involve Aboriginal health workers and also chronic disease team and community COVID medical support officers. So that's Elizabeth's team, drug and alcohol, emergency, GP, mental health, pediatrics. as the younger people are not, like, the vaccination rate is pretty low in the younger population. So we do involve pediatrics a lot, and social work and vulnerable population, DCJ, and youth health. And I'll hand back to Mel to talk about the special health accommodation.
Thanks, Jerry. So here on the Central Coast, we do have special health accommodation, which is referred to as the SHAR for our COVID positive clients, and we have our community support accommodation, which is our CSA for close contact clients that are unable to safely isolate in their home. We do have also a very, very small number of people who, under public health order, are instructed to also go into this accommodation under a Section 63. So the current SHAR CSA capacity is 35 beds, and it is based out at West Gosford at the Ashwood Motel. It's a very clean accommodation, however, it is 2-star, so it doesn't come with all the creature comforts of a lot of hotels, motels would have. So when our clients do go across into that hotel, they're strongly encouraged to bring with them any creature comforts that they'd like to from their home. To make it as comfortable as we can for them, particularly families and if there are young children, because there's not a lot there to keep them entertained. The SHAR CSA is not a Medi hotel. It is accommodation that relies on the people that are there being able to self-care. People that are staying there are able to phone in with Uber Eats or get meals delivered, Domino's, etc. They can contact Dan Murphy's up the road if they choose to get deliveries, also just to try and make it a little bit more comfortable as they would if they were in their own home environment. The motel does have 3 separate buildings, which does enable us as a district to flex the rooms between the SHAR and the CSA, depending on what the demand is between our active cases or close contacts. And it is imperative that we do make sure that we do operate the motel buildings independent of each other, and that's in regards to the infection control and making sure we've got the different zones depending on if it is COVID positive residents or not. So it is a 24-hour accommodation. We do have security on site. We have had police on site, although they're stepping down and just available as need be, but they do drive-throughs. And yeah, a security is there 24/7. Referrals that do come through, the aim is to have all residents settled in by 10 o'clock each evening, and they do receive meals, so they do get their 3 main meals a day that are delivered. And the referral process for us here does go through our public health unit, but if there were any questions or inquiries in regard to people out in the community and their suitability for the special health accommodation or community support accommodation, I would suggest that you go through the community support team initially for those conversations, because most of the patients are going to be known to us anyway. So yeah, so Louise Weymouth is the director of the health accommodation, and yeah, she's done an amazing job very quickly, I'd have to say, to get this accommodation up and going, to ensure that we did have somewhere safe for our active cases or close contacts that are unable to isolate at home safely. And I'll pass over to Elizabeth. Next slide, please.
Thanks. Hi, Mel. Yeah, and thanks, Jerry. Look, it was interesting to hear John talking about the role of, if you like, the doctor in the community. First of all, can everybody hear me? I've decided to put my earphones back in because it's too noisy here with running dogs, etc. So when we initially started, it was very much nursing led, and there was it was identified that we do need some medical input, and the pure medical input has been fairly minimal, I have to say. A lot of our patients are vulnerable. We see a lot of mental health, we see a lot of drug and alcohol. So we've, as Jerry was referring to, we were really heavily relying on having those services involved and actively discouraging people to try and, refrain from withdrawing from alcohol when they're in the hotel accommodation or during COVID, and supporting them through that with sort of relatively safe amounts of alcohol and then introducing them to drug and alcohol so that they could detox or whatever they wanted to later on. And then we also had a very big sort of vulnerable population, you know, domestic violence orders or, you know, that kind of thing that, you know, we had to handle sensitively. So the main role for, okay, and the other medical thing that was people who don't have GPs and run out of scripts. That was the main role of the doctors coming from the hospital. So this was before sotrovimab became available, and that was really why we started a medical like backup on call. And these have been medical officers working in the hospital in various roles. We have ED physicians, we have Scott White, anaesthetist, we've got me, neurology, we've got, you know, hematology, all kinds of things. Upskilling ourselves in, you know, the doses of bronchodilators and stuff. And we basically learned from Southwest Sydney that you probably need a 12-hour shift, because anything that happens after about 8:30 at night and it's bad enough to call a doctor probably needs to go to the ED in any case. So it's not a 24/7. That was their experience, and I think we agree with that. And then, so it may be anything. That person's run out of medication, or, you know, they just feel very anxious and they're still waiting to see the mental health team type of thing. And we've mainly dealt with this through telephone, just because of, you know, so that everybody could use it. But I think telehealth with a video would be really helpful in the longer term. And, you know, Jerry's really looking into that at the moment from previous community health working. So I think if you're going to put up something in their communities, really it's good to have, you know, be able to see the patients for them to see you. I think the other thing that would be good for if a GP is involved is sometimes patients, you know, don't really want to talk to other strange people if they know that their GP is there. But as I said, the very big proportion don't actually have regular GPs. So over to the sotrovimab. As you know, this is a monoclonal antibody really targeted against the spike protein, and has been rolled out now for a specific population that is sort of thought to benefit. So you've got to give it early. So we've got a guideline for within 5 days of symptom onset. People have to be COVID positive. We don't give it to close contacts or anything like that. So they've got to be COVID positive. They should not require oxygen. That sort of means that they probably already needing to get into hospital type of thing. Not fully vaccinated. Or they're fully vaccinated and immune compromised. So that's something that we don't always remember. We have quite a large population of, you know, hematological malignancies or people with chronic diseases like MS or on immune suppressive kind of medications, and their immunity just isn't up to it really. And then, so this background, and then either over 55 or chronic respiratory illness or cardiac illness, obesity. And it's been, and so what Scott Ford has actually done with Mel and the rest is to set up a clinic right next to the hospital in a house that's it's not always there. We were initially thinking we could administer it at home because it's fairly safe, but for just the staff to go out, sit there for an infusion and then make sure, you know, you've got a vascular access. We don't, you know, it's not always predictable. And then you actually need 2 staff to go to a place. So we decided to make the patients just come to a little satellite outside of the hospital. And it's managed really by our medical day unit, nurse unit manager Therese Hallett, who is very skilled in all kinds of IV infusions. And we've like ad hoc been recruiting to some junior doctors to come and you know, be present as well for anything that needs to happen. The infusion itself, I think, takes less than an hour, but people have to be observed for another hour, and you know, it takes a little while to administer or put the drips in and so on. And I guess the other sort of unforeseen, one thing about COVID, you always get these surprises, was, you know, the idea of how does the patient get to the clinic? because they can't take an Uber or a taxi or something. So that if they're well enough to drive themselves, that's good. And they often say, oh no, my son or my daughter can take me. And I say, well, are they isolating with you? No, okay. They can't bring you. But yeah, it's going very well. I think there's been one person with anaphylaxis, but luckily that was picked up quickly. And yeah, we'll see how we go. Right, I think I'm back to you now, Mel.
Yeah, so I thank you, Elizabeth and Jerry. So that does bring us to the end, but I guess I'd just share with you just very quickly a little bit of a patient story where the community support team do a lot with not just monitoring the symptoms of COVID and the well-being, but they do get some curly questions every now and then. And I know it was shared with me where, you know, these people, the families are in isolation for 14 days and things go wrong. And we had a family where they were having some plumbing issues and they couldn't actually wait for the blocked drain. It needed to be sorted. And so they were able to support this family with arranging, I guess, virtually a plumber to talk them step by step how to actually fix their problem, which, you know, meant the world to them and meant that they could continue quite safely in their home. So there are little curveballs that come to the team, but they try and help people to navigate those curveballs, because a lot of people in the community aren't used to being in isolation and don't know how to connect with various services when they need to. So yeah, I just thought I'd end with that little story because it's something's a bit different to what we do out in the community within health. But yeah, thank you everyone.
Thanks so much, guys. Thanks, Mel. That was good to finish on with a personal story, a patient story. A couple of the questions for you just before we throw to Jill and Erica. One relates to the intention to increase capacity of the SHA accommodation, given the modelling demonstrating the increased cases. I assume that will increase if needed.
I would say that would just be a conversation, because they have, I guess, decreased capacity recently. So they do, depending on demand and what is required. Of course, they do flex between the CSA and the SHA as much as possible. And if the demand was such, I guess it would be reviewed around what is required. But yeah, we have just recently decreased.
Yeah, so that's an evolving space too. That's good to know. And the other question relates to, I guess, providing that social and emotional support to patients who are isolating at home. It sounds like you guys do a lot of that, but that's also where the GP can come in as well. If the GP knows the family very well, I'm imagining if there's a great escalation of case numbers, then we'd be ideally placed to step in. Karen, did you want to comment on that at all, or Catherine?
Thanks, Ellie. I guess importantly, you know, we are asking to be part of the team and to be communicated with quickly or as soon as possible. I guess my only comment is that the positive patients that I know that we've had in our practice, sometimes it does take up to about a week to get the correspondence, which actually does come into my inbox. It's great. It's I would just let everybody know that it looks like a discharge summary that comes from the hospital, but it doesn't appear to be complete. And if you look up into the left-hand top corner, there's a link which is blue writing, and you can click on that and can open it up, and it will actually indicate that this person has tested positive and is in isolation. And I presume, Mel, it will actually tell us that this person might be in the SHA if they need to be in, possibly not. So I guess what that correspondence is it's telling us as the GP that your patient has tested positive and that they're now in isolation. Also gives us a bit of an information about when the patient is due to be released from isolation, and it tells us that the community support team will stay in touch with them. So I guess there's nothing on us at the moment as an onus to contact these people, but it certainly would very much help Elizabeth and the team, I'm sure, if we do contact the community support team to let them know if we feel that this patient requires Sotrovimab or has a concern with their health or perhaps a need. And I guess at the moment, because we've got so few numbers, we're seeing most people asymptomatic or with limited symptoms. I mean, I personally have reached out to a couple of our patients and just given a call. Most of our patients have been very happy to receive a call and actually really pleased to know that I know, and just letting them know that I'm there if they need. One question I guess I have, Mel and Elizabeth, is you were saying that many patients of these, many of these people so far have not identified a GP. Is there something that we can do, and I'm saying we as GP community, can we help you out with that? Because writing a simple script is often not that hard for us, and I could imagine it could be difficult for you guys if you don't have access to the IT systems that we do. And I guess if numbers do increase fastly across the coast, is that something we could be on a sort of a group of GPs as an on-call? But that's something we can talk about perhaps into the future.
Yeah, Karen, I can see that that's a definite possibility. And yeah, I mean, I think so. I mean, ideally, it would be fantastic if the moment the positive test came through, the GP could be notified. Because even though it's convoluted, it goes through the public health network and then to outcomes to the community team. So it takes time. And we just accidentally had somebody who works in the respiratory clinic who knew that a patient was positive, but also works in the COVID team and thought this would be a Sotrovimab candidate and sort of gave us a heads up about the name, and then we could fit that person in. Where if they'd waited for the sort of slow machinations, it may have been too late. And what I want to say to everyone is to let your patients know, especially your unvaccinated patients, about Sotrovimab. So I'm always surprised. I've asked my patients now to let me know whether they're vaccinated or not when they come for an appointment. And you're surprised by who's not vaccinated. I still see them, we still talk, but that gives me the opportunity to say, at least, look, if you do get sick, you have to let someone know because there is this infusion you can have, type of thing. So a conversation with patients about what is available if they do get sick.
So can I then throw back to you, Elizabeth and Jerry and Melissa, why can't we get more timely communication from you? What can we do to actually make sure that the GP is communicated with it as soon as possible?
I think that's something Mel.
Yeah, because I think we only get notified later. Yeah, so when Jerry will be able to tell us how quickly he tries to notify GPs. Jerry, when do you send out the signal?
We send out the signal as soon as we complete the initial assessment. A letter to the GP will be sent.
Do you have a ballpark figure about how long it takes from when a person is sort of tested COVID until you know about them?
Yeah, depending on how fast public health can do their bit. So because we get the referrals from the portal, which is coming from the public health. But recently we did do a trial of ringing every GP regarding their positive patients.
Yeah. So yeah, it's Melbourne. So once public health unit complete their case interviews, and then there's the process of them coming onto a portal when the community support team do take the patient straight off there immediately. So the same day if it's within the business hours, otherwise it's the next day. And our patients are then contacted that same day for their initial assessment with us, and then the notification once we've done that assessment and confirmed their GP, if they do have a GP, will go out on that same day.
Yeah.
So we have done some, because I think we had some feedback, Karen, previously, and I think we've been trying to look at how we can streamline that. And yeah, as Jerry said, with the numbers being quite low at the moment and have been for the last couple of weeks, we've been making quite an effort to ring the GPs as well, even if it's just to your admin staff, just to let them know that something will be in their inbox.
Yeah, now's the perfect time, isn't it, while cases are low, to streamline all of these things and really try and hone them before things kick off again, which is a good segue into our next presentation. Thank you so much, guys. So we'll go to you, Erica, and Dr. Jill Sass to talk about health pathways, and thanks so much.
Thanks very much, Ellie. So, yeah, Jill and I will present on health pathways and what's been updated recently and newly published. So I'll just click through our slide. Hopefully this is showing okay. Slides are a bit slow tonight, apologies. Is that advancing to the next slide? I just want to check.
Not yet, Erica. Yes,
there we go. Sorry, it's a bit slow tonight. Thanks, Mel.
Yeah.
Great. So just so everyone's aware, Health Pathways is designed for health professionals in our region. So the website and login details are there for you. And we've also got a companion website, which is for patients and the general community. So health professionals can share that with your patients. And there's information specifically about COVID on Central Coast Patient Info. All right, so Dr. Jill Sass, who's one of our GP clinical editors in our team and a local GP from Point Clare Medical Practice. She's been working very hard on updating quite a number of the clinical pathways in our Health Pathways website. So they've been updated in line with the latest situation and the phase of the pandemic that we're in currently, and also the Central Coast LHD COVID community support team and the shared care that we're moving towards in the Central Coast region. So the pathways that Jill's recently updated include the shared care in the community pathway that we presented on several weeks ago at the last webinar. That's been updated a couple of times since then. Also, we've just recently updated the assessment and management in children. There's some new resources from the Sydney Children's Hospital Network and some information that Jill has updated regarding children's care in the community. We've also revised the pathway that was previously titled Initial Assessment and Management, and that now has been rewritten by Jill and updated to be Respiratory Presentations During COVID. The testing and referrals page has also been updated, so all of the Central Coast LHD services that Mel, Jerry and Elizabeth were talking about and the direct phone numbers have all been compiled into that one referral page. We've also got the isolation support page, so we're continuing to add social support providers that can provide remote support, such as what the presenters were talking about earlier, such as mental health support that could be done over the phone, for example. And we've also got the post-COVID conditions pathway as well, which covers long COVID and the potential impact on that cohort of patients who experience symptoms over the longer term. Okay, so also two new pages. So the New South Wales Health Pathways regions have collaborated and there's New South Wales wide pages that have recently been published to our sites. So that includes a page specifically on PPE, infection control and exposure responses at this stage of the pandemic. So that's what we were talking about a little bit earlier with trying to reduce exposures and furloughing in practices. And there's also a useful page that has a lot of templates and forms called Case Management Tools and Resources, and that would assist you if you are managing patients remotely and in their home isolation. So we hope that those resources will become useful over the next weeks to months. So this is just a snapshot of what the COVID shared care in the community pathway looks like. And you can find that obviously in the COVID section and then under COVID assessment and management, that subsection there. And Jill will talk about this in a little bit more detail and give a demonstration just after this. And similarly, respiratory presentations during COVID-19. So that's also in the same section, assessment and management. I also just wanted to specifically mention that we've now got a page on Central Coast Patient Info specifically about COVID isolation support, and the Central Coast LHD have generously shared with us an information pack that their team has been sharing with patients in isolation that has lots of helpful information sheets for patients. There's lots of phone support helplines, what to do if they need assistance remotely, if they need financial assistance, mental health support, and so on. So we've included that in the shared care in the community clinical pathway, so GPs can access that and share that with their patients, but it's also available for the public through Central Coast Patient Info with no login required. And then, as always, you're welcome to contact the Health Pathways team, and we're always happy to receive feedback through either our email address to myself or through the send feedback button on each page, and we'll endeavour to improve Health Pathways continually and address any feedback that you send through. So now I'll just hand over to Jill. We'll just go into the live site and we'll give a demonstration. So hopefully that's displaying okay. All right, and I'll hand over to Jill now.
Thank you, Arrowhead. I just first of all just wanted to take you through the COVID-19 assessment and management pages that we've updated. So I'll go quickly to the shared care. So this is just reflecting the current model, which is basically mainly managed by the local health district hospital team at the moment, and it's based on GPs assisting in that care and providing their normal care, but also in the anticipation of surge of cases that reflecting on what the current guidelines are. Perhaps you'll be contacted initially, particularly with the increasing use of rapid antigen testing to give a guidance of the processes. So
yeah, I'll just minimise that. Thank you. We're just minimising the control panel here so that we can view it better.
Thank you. So importantly, there's just on the sideline a lot of key links and key guidelines that can easily link into with the National Task Force, the ACI guidelines, RSEQP guidelines, and on the side, then obviously with the red flags, this is pathways based on managing currently via telehealth. So there is another pathway that can be localised for full GP care for face-to-face, but that hasn't been localised as yet. Importantly, it talks about what the current involvement is for the LHD and the guidelines there for the ACI. Just get rolling through about assessing risk. We've just started outlining different ways of assessing risk. And we've got a link here which can take you to the current National Clinical Evidence Task Force guidelines as a handy link in assessing their risk and their symptoms and where their appropriate care then should be. We've then got a link here about suitability for sotrovimab, so that links the criteria there and some of the guidelines there, the documents linking to the sotrovimab use. Guidelines about remote examination via telehealth, including adults and children. And then moving to management, this is when we can now link directly to the referral page, which is outlining all the information that we've heard and presented tonight with all their contact numbers for the community support team, the medical support team, the paediatric monitoring team, and the support accommodation. And this can be fleshed out and added as we get more information as well, and particularly we can put a new heading in there about the sotrovimab clinic referrals. in the management, there's a lot of information and resources there. About the RCGP management links. There is information about interpreter services, breastfeeding support, pregnancy support, mental health support, and management, medication management, remote scripting, drug and alcohol support, and then in the information at the end, just a lot of guidelines there and for patient information. And I just wanted to also go to the newly localised page of assessment and management for children, because I guess we'll be seeing a lot more children with mild symptoms in the community, and that also gives a lot of information about the current COVID-led hospital service, the monitoring team, and the services available there. So at the moment, it's just mainly reflecting the current model, but we'll just help with the GPs about, if you're seeing these patients, about assessing risk and how to escalate care.
Great, thanks, Jill. So we might hand back to Ellie and Karen, and we'll hand over for the question and answers.
Thanks so much, guys. It's wonderful to see all that work you've put in. It's incredible, all those pathways. I will just comment, sometimes it's hard for us to find bat phone numbers and contact details. I wonder if that's something that we could put maybe on the Health Pathways homepage, just a quick link to COVID contact details. That page where you listed all the numbers beautifully was buried a little bit some way down. It would be great if we're in a hurry, just so that we can click on those. And yeah, it's fantastic what you've done there. Thanks so much.
Thank you.
A lot of our questions relate to, it looks like, wearing PPE and what's going to be appropriate in certain situations if we're expecting increased case numbers, and avoiding being furloughed as GPs, including in their practices. A couple of people have asked about where to find the health worker exposure risk matrix, which is a really useful graph for others who haven't seen it before, just detailing exactly what is going to protect us in that situation. It looks like N95s and eye protection pretty much guarantee that we wouldn't be furloughed in any positive case situation. Many of us are just wearing surgical masks and goggles or eye protection, and that is still enough, it looks like, from the matrix, as long as you're not performing aerosol generating procedures or in contact within 1.5 metre distance or for more than 15 minutes. So that's worth bearing in mind. Does someone else want to highlight some points? Karen, maybe I'll throw it to you, and I'll try and share my screen just so I can show that risk matrix while you're chatting.
So Ellie, I've just been trying to look for that risk matrix so I can put it up for a link for everybody, but I've only got it as a PDF. So
I've got it. I can
you've got
show it. Yeah. Was there anything to go over?
It's on Health Pathways, it is. So it's a really useful matrix to assist your practice and your practice managers and nurses and doctors to actually understand the type of patient that might come in. And I guess it's those people who we least suspect or we just do not know. And I think that's going to happen more and more for us as well. And as you can see with this risk matrix, is that if you look at the green area, it's the low risk. If you come right down to number 6 on the left-hand side and look at the staff member in a P2 or N95 mask and eye protection, with no concerns for breaches of that. And that means you don't have to wear a gown unless, I guess, it's aerosol or a lot of liquid around. And if you're wearing an N95 mask and eye protection and you find out that a patient has actually entered your practice or been in your practice and you have actually seen them face to face, you are actually in the green zone. It's a low risk. If you can indicate that you have actually been wearing your N95 mask and eye protection. So at this point in time in my practice, that's what I do. Unfortunately, I am seeing my patients face to face in an N95 mask and eye protection. And normal glasses are not enough. It needs to have a covering over your glasses or your eyes. And I guess if we're in a surgical mask and you do have a positive patient that you're unaware, then you probably will be asked to, by PHN, depending on contact, will be asked to have a swab and PCR swab, and really, if doubly vaccinated, you will probably need to stay in isolation for 5 days until your next swab is negative. So, you know, I guess there's another question on there, Ellie, and it's about if we're going to need to still wear N95 masks, and this is out to you, John, will the PHN continue to supply these to practices?
So the answer to that is if you express an EOI to see face-to-face patients, you'll be able to draw on the national stockpile.
Thanks, Jen. That's good to know. Catherine Palmquist, you had a comment there. Jump in.
Thanks, Ali. The other thing our practice has talked about amongst ourselves, which is not just generally advice for all practices, but the rapid antigen testing of a patient that might be coming in for a longer procedure, say a skin excision, that the benefit of them having the excision outweighs them waiting for a safer time period. So whether patients get tested prior to coming into your clinic for an extra element of safety. The other thing I wanted to mention, just with the Citruvimab, it's really worthwhile having a look at the guidelines on that again. The RACGP's put out a really good worksheet on it, but it's surprising how many people may still qualify for it. So it's really worth having it at the forefront for any of your patients. The PHN, not the PHN, the LHD will obviously be chatting with patients, but there's some intricacies that patients have with their health that we are privy to, I guess, with our databases on them. And it's surprising, again, what illnesses qualify for that. And also post-Citruvimab management of your patient, especially around vaccinations after they've had it. So it's really important to kind of look through those guidelines and be up to date on that.
Thanks, Catherine. From memory, is that currently we're advocating for any time after 6 weeks they can be vaccinated post-infection?
Okay, so that's really important. If they've had their infection, they can be vaccinated basically when they can. If there's short supply around and the burden of disease is around, they recommend when you can actually vaccinate. If they've had Citruvimab, it changes. So I think the current guidelines say at least 6 months after that, but I'm not 100% on that detail, but it's definitely much longer to be vaccinated if they've had the monoclonal antibody.
Mel or Elizabeth, do you want to comment there?
Elizabeth might know that, but she's on the phone, Ellie, at the moment because she's on call. So might be something we could actually ask her, unless Melissa or Jerry know.
I'm not sure about post the infusion, but I just know once someone has been released from isolation, and if they weren't vaccinated, that they part of their release information does encourage them to go and have their vaccination as soon as practical, and that they are feeling well enough to go and have it. So, yeah.
The last I heard after having the Citruvimab was 6 months, and that was for any vaccine as well. So it is really worth being specific and very clear on that. And also, if a lady was pregnant and had the infusion considerations of the newborn baby's vaccine schedule as well.
Yeah. Thanks, Catherine. We've got a question there just quickly for Mel. Where do we refer patients to get Citruvimab? Is a question from the audience. I assume they call you guys?
I would go, Jerry, you're right, through the community support team, yeah. So because they should be a patient that's known to us anyway, and we have a direct referral through internally so that it goes to Dr. Scott Forty or Elizabeth Reneke, who will then review the files and do a bit of a case interview if need be with the patient, and go through obviously all the instructions, including have you got enough fuel in your car and don't stop anywhere, not even for bread and milk on your way. So yeah, just through the community support team, which the link was in our presentation.
That's great, thank you. Really good question from Sarah Houlihan. What is the panel's thoughts on spirometry in general practice at the moment, please?
Oh, I guess I'll jump in there. Certainly during the first lockdown, it was recommended that we don't use any form of respiratory function testing. But I guess again, if you can utilise, you've got to be cautious, and so anybody who's doing spirometry or peak flows, you need to be in a well ventilated area, and the people who are actually your staff who are actually performing the testing really needs to make sure that they are in appropriate PPE whilst they're doing it, and you need to probably be able to clean the room after doing it. So we've gone back to doing spirometry. We do it with the door open so that people are actually relatively almost outside. But I'd be very cautious probably about doing it in an enclosed room without good ventilation and without PPE. And when I say PPE, it's again an N95 mask and eye protection for those who are actually doing with the patient at the time. Does anybody else?
Add to that, Karen,
that
the important features that they're telling us moving forward are social distance with people, PPE with our patients, and ventilation. Those are the main things we can control.
Absolutely.
But I guess the ventilation's got to go. Sorry, I just had to jump off there for a moment, Mrs. But it doesn't help if it ventilates into the waiting room. It's got to be outside ventilation.
Proper HEPA filters, preferably, and proper ventilation.
Elizabeth, we just had a question when you were on the phone, and it was actually a statement from Catherine, which was really helpful and useful. If a patient has had sotrovimab, how long after that can they receive a vaccination? Do you know the answer to that?
Look, I think the same. Probably, once they're well. I don't think the antibodies live that long. So, a couple of weeks when they're feeling well again. So, I mean, you might remember in the beginning when we had the people with COVID were not allowed to have, or what they were told they're not allowed to have the vaccination for 6 months. And now that's really come down to as soon as they are feeling better. It is hard to know. I mean, it's the kind of I'm not aware of any hard and fast data. Well, clearly you don't want the neutralizing antibody to neutralize your vaccination, but I would say most antibodies like that are not going to hang around for maybe more than 4 weeks. So perhaps 4 to 6 weeks.
I'll just jump in there. I'm just looking at Monash Health information for patients, and they're actually saying 3 months.
All right. No, I wasn't aware of that. Yeah.
So, but that could be old data. That was written, I think, on the 6th of October, 21. So
they've brought everything back down since then. Yeah.
Yeah.
Actually, on Health Pathways, we do have in our shared care page, we have some drop-down boxes about vaccination after COVID infection, and there's a specific drop-down box about vaccination after sotrovimab. It's already on Health Pathways with some guidelines there.
Yep. Good.
Thanks, Jill. That's great. A couple more questions and then we'll wrap up. I think it's been such an informative night. Thanks, everybody. A couple of just things to clarify, John, if you wouldn't mind. So is it true that GPs will only be fit tested in 95s if they sign up to the EOI? or can any general practice apply for fit testing?
The PHN will pay for fit testing for GPs who sign up to the EOI. So that's that's part of the offer.
Sure.
Would there be a way for GPs to access a fit tester and pay for that? Because I think access to actually someone fit testing is quite difficult as well.
We've got a list of companies that do fit testing, so we can certainly provide those. I might even provide those to Erica to be included on an appropriate spot in Pathways. Yep. There are a number of mobile fit testing services around, yeah.
The LHD offered to fit test some of our GPs. I wonder if there's room for cooperation there if needed, if things kick off, but we can have those conversations separately. There's one last question from Lynn Hayes. If anyone's got tips for where can you get goggles that fit over glasses?
Fong did provide me with a source. I'm happy to share that as well. I'll get that to the GP group, but Karen might know because she's a wearer of glasses.
Well, we sourced them early on and they were about $20 each. They're actually quite good as long as you don't scratch them. They are plastic, but you can also go to the OPS, I won't say OPSM, I shouldn't name names, but your favourite optometrist, and there's some fantastic glasses you can get if you're a script wearer. You can get those into glasses that aren't as expensive as the glasses I have on, or you can actually get covers as well. But certainly, I know John does have a couple of lists. I think, is it from Health Pathways, girls, where we can actually get those? I know we talked about that early on about some sourcing of them. But Lynn, I'll let you know where we got ours from if you like.
That's quite
useful. Karen, David King from the audience says Bunnings. That's an easier.
Yeah, we've worn those Bunnings ones as well. They're quite good until you want to see out to the side, but they are very helpful, and it is pretty important to put them on.
Thank you, guys. I might wrap up there. It's been a really informative night. Just one point from Taya Van Haren in the audience that she says, and I think that's on everybody's minds, as GPs, we are happy to look after our own patients, but we do require financial support. So, John, that was what you were alluding to. You're working out some appropriate remuneration for the GPs who sign on for the home visit scheme. Telehealth isn't enough generally to cover our costs, and there shouldn't be an expectation, she says, that we would bulk bill, so there's no rule about that now. And I guess while we've got our hospital colleagues here, it would be nice for you guys to know that a lot of us can't bulk bill anymore, so we will be charging private fees for telehealth services. So just be mindful that perhaps not to explain to patients that your GP can call you for free, because we will need to charge sometimes for our services. But that's fantastic. And I guess on that note, I mean, you have seen the GPs here online advocating for you, and we'll continue to advocate for general practice, and hopefully you've seen that we're all approachable and we've got your back. So if you need to get in touch with us, reach out to the PHN and they'll put you in touch. We do have the COVID Central Coast Community of Practice and the Central Coast GP Association on Facebook. So if you're not a member of that, please do join up and we'll continue the conversation. But thanks so much to all of our presenters and guest speakers, and thanks to PHN for organising. I hope it's been an interesting night.
Thanks so much, Alice, and thank you for facilitating tonight. Thank you for everyone for being with us. Just a reminder that there will be a poll that will pop up at the end of the session. I do strongly encourage you to complete that because we do use that data to forecast our further education events. So thank you everyone for being here with us tonight, and thank you for engagement. Really appreciate it. Good night, everyone.
Thanks, everyone.
Thank you.
Good night.